And I'd like to introduce Luciano, first of all, from the Asthma PAG. And he's going to tell us a little bit about what he has done in his work with the Asthma PAG. So over to you, Luciano, please.
Thank you. Thank you very much. It's a pleasure to be with you this morning and to report about a very productive experience ahead. I'm a Severe Asthma Patients Association leader in Italy, and I'm a member of the Asthma PAG, of course. Next slide, please. I was involved into two projects. The first one, two research projects which are leading toward papers to be published. The first one is with the SHARP registry that is across Europe. They are looking at the characteristics of elderly severe asthma patients, and the acronym ELSA is the name of the study. The study is going to provide a real-world picture of how aging is going to affect the severe asthma patients and to enable personalized and age-sensitive management of the condition and of the treatment. Here you see what are the primary objectives: assess the relationship between aging and the relevant characteristics of adults with severe asthma in Europe, explore key differences in disease phenotypes by age, and analyze the trend of clinical and inflammatory outcome over the course of biologic treatment age. We are looking at the data of 16,748 patients throughout Europe, out of which 4,521 are the elderly. Now, the early findings, as you can expect, is that many parameters show an age effect, but there are some surprises that we are having, and there could be potential implication for treatment guidelines and policy. For instance, this is a big surprise for all of us, is that the cortisone use is increasing with the age throughout Europe. And the comorbidities pattern that is shown by the study, but the statistics of the study is really amazing, some particularly in the cardiovascular area. So the project is going to describe what it is today in the real world of the severe asthma, but it will indicate areas for further research to the European specialists, of course. The group which is leading the team is a team made of 41 people from 23 countries, and there is a core group of 8 doctors and 1 patient, me, which are trying to prepare the work for the larger group. Now, the second project is for a task force for the ERS, which is trying to define what is how the severe asthma remission can be defined and identified. It's a big question, because the team has to declare what is the time frame after which you can be declared in remission, what are the minimal symptoms that you can afford, what is the level of lung function optimized and stabilized to allow the declaration of remission, what's the quality of life test, of course, what is the reduction of inspired corticosteroids and the long-acting beta antagonist. And there must be, that's a novelty, a patient and specialist agreement. Of course, we are stressing that the remission has to be defined whilst the treatment is on and it's not stopped. Thank you. Next one, please. 27 healthcare professionals attending from all Europe and Canada. There is a steering group that prepares the work of 10 members. 3 are patients. It's myself, Dominic Hammerling, that is in the meeting, and Hilary Hodge. There are bi-monthly meetings for the big group, but we are meeting and working a lot more between one meeting and the other. What went well of this experience I had, and what could be improved? First of all, we were well accepted and very well listened to. There was an excellent buying in of our contribution. And I brought personally the experience of a large group, 130 patients, which are an homogeneous group, all visited by the same specialist, all cured at the same hospital, and all followed by the same association, of course. What we need improvement, two things, I think. The first one is the language. Some of the people in the team are speaking a very difficult English, of course. And second, I had to follow the scientific language, which was quite difficult, particularly in the acronyms. Like your experience when I say ICS, which is inhaled corticosteroids acronym, of course. They are using a lot of acronyms. They understand each other instantly. I had to ask for explanation, of course. The second, there was a specific inequality of economics. Let me tell you what was the episode. I've been invited by the task force as a task force member to a meeting at the ERS Congress. Of course, I was given a budget by ELF, and then the budget was actually the cost of the hotels in the main Congress site was 3 times the budget that I was given. So ERS helped by doubling the budget, and actually with that budget, I could take a room far away from the main Congress site, and I had difficulties to reach them. I had to use public transportation, and of course, there was quite a lot of distance. I decided not to join in person. I decided to join online. Then I discovered later on that in the ERS policy, it's written that members of task force attending the Congress have to be fully reimbursed. So that if that is the statement for the doctors, why shouldn't that be the statement for the patient involved into task force as well? So that was the question I was reading. Next slides, please. Our contribution was quite well taken by the ERS people in the task force. In the report at 1 year time, they were saying that the patient perspective has been fully incorporated. The support from the ELF PAG was effective and fundamental in shaping some topics, and the patient impact was scored as high, influenced the project by introducing 3 substantial key points. If we get the next one, please. And these are the 3 key points that we introduced. Quality of life has to be recognized as a key point to define remission. So not only based on clinical parameters, but as well on the result of the quality of life testing. The treatment with biologic must continue, notwithstanding there is a remission, a definition of remission, of course. And third, there must be an agreement between patient and specialist, because we were fearing that if the specialist identify the clinical parameters and say you are in remission, but the patient continues to have a miserable life, the patient cannot be defined in remission as well. That's about it. This is the team of Asthma Grave Association in Italy, which I wanted to show to all of you. And that's all from my side. Thank you very much.
Thank you so much, Luciano. And